Hi, good evening, guys. Am I audible?
Yes, Sonia. Good evening.
Okay, good evening. So, surgery. So, intersex surgery is nothing but if a male is, if a male or female has gender dysphoria, like they could identify the gender and they want to like get a transition from male to female or female to male. So, in that case, if they are transforming from male to female, in a sense, they will get a breast, surgery done. Okay, they will, what to say, they'll just, proceed with surgery for, creating an artificial urethra and, setting an uterus and ovaries and all. But if a female is converting, transforming into a male, then definitely she will, do breast reduction and they will also be doing creating male reproductive system inside them. Okay, so 55970 is for intersex surgery from male to female, and 55980 is for female to male. So coming to the female genital system, we have the female genital organs over here. So we can see the vagina, the cervix, right? The uterus, the endometrium. We can see the ovaries. We can see two ovaries left and right. Then we can see the fallopian tubes. Right? So this is the fundus of this uterus. Okay. So this is the fundus or upper part of the uterus, right? So we have the ligaments behind supporting the uterine wall and the structures of the reproductive system. Then we have the ampulla, okay, which branches into the infundibulum with fimbriae. So there are a lot of fimbriae in the fallopian tube, which makes an texture like bed for the eggs, okay, to to flow into the fallopian tube and then into the uterus. Okay, so the fertilization happens in the uterus, right? So the eggs are developed in the ovaries. Okay, so this is the vagina. Okay, the lower part of the vagina. This is the cervix. Okay, so you have the cervical canal over here. Okay, this is cervical opening. Okay, and then you have the uterus where the fetus grows. Okay. Okay, coming to hysterectomy. So what is hysterectomy, guys?
Removal of uterus.
Removal
That's
of
all.
uterus.
So only uterus will be removed?
Yes.
Okay. So hysterectomy, yes, of course, uterus will be removed, but along with uterus, sometimes fallopian tubes and the ovaries and the cervix, everything will be removed. Okay. So we'll just see the test. Just give me 2 minutes. So, as we were talking, hysterectomy is surgical removal of uterus. Along with that, am I audible, guys? Yes, no?
Yes, sir.
Yes.
Okay. So, as I told you, along with uterus, sometimes the upper part of uterus, okay, sometimes the whole uterus with cervix will be removed, and sometimes the uterus, cervix, adjacent tissues, and the ligaments, surrounding ligaments can also be removed. So, we have terms such as total hysterectomy, radical hysterectomy. Okay. So, total hysterectomy is nothing but they'll remove the whole uterus along with the cervix. Okay. And radical hysterectomy is that they will remove the whole uterus, and along with that, they will remove the cervix and adjacent tissues and top part of the uterus. Okay. So, that will be removed while the procedure is radical hysterectomy. Okay, so radical hysterectomy is nothing but surrounding tissues and parts and everything will be removed along with the organ. Okay. Then we have the supracervical or subtotal, or we also can, name it as partial hysterectomy. So it is nothing but is a removal of upper part of uterus. Okay, with cervix in. So cervix will be intact, left intact. It won't be touched or it won't be removed. Okay, but the upper part of uterus will only be removed. We call it as hysterectomy. Okay, so the coding part for hysterectomy is that coding elements is that you should know what the approach is, whether it is an open or laparoscopy. If it is an open, we should, check whether it is abdominal approach or vaginal approach. Okay, so there are two ways they can do the hysterectomy. One is abdominal or vaginal. So abdominal, this is they will make a big incision on your lower part of the stomach, and then they will get through the structures and get into the uterus, and they'll try to remove it. But through vaginal, they will, the second approach is through vagina. So in vagina, they will be inserting some instruments, and then they will try to remove the uterus and other structures through vagina. So there are two approaches in order to um, do hysterectomy. So again, if it is abdominal or vaginal, you should make sure that it is an open type or a laparoscope. So even in abdominal, hysterectomy, they will use trocar, okay, or scope, and they will do abdominal hysterectomy too. So in that case, you will have a different CPT for laparoscopic abdominal hysterectomy, and you have a different CPT for open abdominal hysterectomy. Likewise, you also have it for vaginal too. Okay, so that is one thing. Then you need to check for the extent of the uterus has been removed, whether it is like for partial, like we call it a supracervical or partial hysterectomy, or it is a total hysterectomy, or it is a radical hysterectomy. So that is one thing you need to be considering about. Then the next thing is the weight of uterus. So weight of uterus is very necessary to code, to pick the code actually. So so when do you know the weight of uterus? So weight of uterus is known in pathology report. So whenever you get a hysterectomy chart, first thing you need to check is that whether pathology report has been updated or not for that particular DOS. If it is not updated, you have to pen for pathology, or you have to query the provider for the pathological report. If it is there, then definitely you can proceed with the coding. But if it is not there, then you cannot touch the coding part. Why? Because if you want to code for hysterectomy, you should know about the weight of uterus. Because again, your CPT is divided by the weight of uterus and as well as the approach, whether it is open or laparoscopic. Okay. Then we need to check if they are removing the fallopian tubes and ovaries or not. Okay. So this is one thing. And then we should check if they are doing any additional procedures along with hysterectomy, such as repair of enterocoel. Enterocoel is nothing but intestines. If they are repairing the intestines, okay. So in that case, we'll append CPT for repair of enterocoel. Or they are removing vagina. So if they are partially removing a small part of vagina, then we can code for partial vaginectomy. We have combination procedures. Okay. So that is one thing. And we need to see if they are doing hysterectomy after a C-section. Okay, so the patient might be, uh, you know, um, delivered a baby, few months or few years, and now they're coming for a hysterectomy. So that also have to be coded separately. Okay. So coming to open hysterectomy codes, we have like open hysterectomy codes and laparoscopic hysterectomy codes. So for hysterectomy, as I told you, we need to check for open. If it is for open, we have to check vaginal or abdominal. So abdominal, we have CPTs like 58180 for supracervical. Okay. Height 180 for supracervical abdominal hysterectomy. Okay, so they might remove or may not remove tubes. Okay, that is not like if even if they are removing the tubes and the ovaries, it is inclusive to the CPT 581180. Okay, so this is for supracervical hysterectomy of open type. Okay, the approach is open type. Okay, and the second approach is abdominal. Okay, and we are doing supracervical hysterectomy. Then, coming to the total abdominal hysterectomy, we have CPTs called 58150. Okay, we have 58200. Okay, total abdominal hysterectomy with or without removal of tubes and with or without removal of ovaries. Okay, this is for total hysterectomy. Okay, that is to remove the uterus totally. Right. Then we have 5200. So this is for total abdominal hysterectomy, which includes partial vaginectomy. So I told you, right, the combo code we have. If they are removing partial vagina, okay, and they are doing any pelvic lymph node sampling. Okay, so in that case, it is 58200. Now coming to the radical. So radical is nothing but as I told you, they will remove the uterus along with the other structures. So we have 58210. Okay, so radical abdominal hysterectomy with bilateral total pelvic lymphadenectomy and para-aortic lymph node sampling. So they might do lymph node sampling, they might do the pelvic lymph excision, okay, bilateral total pelvic lymph excision. Okay, so if that is the case, then you can code 58210 for radical abdominal hysterectomy. Now coming to the vaginal part. So for vaginal, we will be checking the weight of the uterus. So if the uterus is less than 250 gram, so you have like less than 250 gram and more than greater than 250 gram. So if it is less than 250 gram, we have CPTs 58262. Vaginal hysterectomy for uterus 250 gram or less. Okay, so this is for 58260 is for they'll just remove the uterus through vagina. Okay, and the size is 250 gram or less. But if they are removing the tubes and ovaries along with the this uterus, then your CPT is 58262. Okay, and if they are removing the ovaries, tubes, and everything with along with the repair of enterocoel of the intestine, we have 58263. Okay. So this is for 58275 for vaginal hysterectomy with total or partial vagina. So if they are doing a vaginectomy, they are like resecting a part of vagina, okay, through vaginal hysterectomy, then our CPT is 58275. And if they are doing a radical vaginal hysterectomy, we have 58285. Now 58290 is for the uterus greater than 250 gram. Okay, and if they are resecting tubes and ovaries, we have 58291. So this is for the repair of enterocoel. And if they are just removing the enterocoel along with the hysterectomy, then your CPT is 58294. Okay. Now coming to the laparoscopic approach. So whenever you're coding for laparoscopic hysterectomy, again, we have like vaginal and total. Okay. Um, so supracervical. Okay, so for supracervical, we have uterus 250 less than 250 gram or greater than 250 gram. Okay, supracervical, I told you, right? We'll just remove part of the upper part of the uterus. Okay, that is what they will do in that. So, if they are removing the uterus, which is of 250 gram or less, okay, and they just remove the uterus, okay, alone. And if it is a supracervical hysterectomy, our CPT is 58541. Okay, and this is for laparoscopic. Supracervical hysterectomy for uterus less than 250 gram. They are removing the tubes and ovaries along with this uterus, supracervical uterus, then we have 58542. Okay, if it is greater than 250 gram, we have 58543. Okay, and 58544 for the removal of tubes and ovaries. Okay, then if they are doing laparoscopy surgical with vaginal hysterectomy for uterus less than 250 grams. So this is what you'll get frequently. Okay. So if it is less than 250 gram, we have 58550. So this is like, what to say, they'll remove the whole uterus. Okay. And 58552 is for if they are removing the tubes and ovaries along with the uterus. And if it is greater than 250, we have 58553 and 58554. So this is how you they see this is a radical hysterectomy, like they'll remove the structures and everything. Here there's a total hysterectomy and the uterus will be removed. So sometimes they might take the fallopian tube or ovary, sometimes they might not. So uterus definitely they will remove, but you need to check if tubes and ovaries are also removed along with the uterus. If they are only doing a visualization of the vagina, the uterine, the uterus part through a scope, we call it as hysteroscopy diagnostic. It is a separate procedure and we need to put 58444. But if they are doing any biopsy, okay, from the endometrium, or if there is any polyp in the uterus and they are removing it, okay, sometimes they will do dilation and curettage, or sometimes they might not. In that case, your CPT is 58558. Again, this is very frequently seen CPTs. If they are removing any additions, if they're lysing any addition, we have 58559. So these are all straightforward, guys. Okay. So leiomyomata is a tumor of the uterus. If they're removing leiomyomata through hysteroscopy, your CPT is 58561. Okay. If the surgical part, the hysterectomy is through laparoscopy. I mean, the total hysterectomy is done. Our CPT is 58570. If it is less than 50 gram, we have 58570. If it is more than 50 gram, we have 58572. Okay, and 58571 is for the removal of tubes and ovaries. So for removal of tubes and ovaries, you need to check carefully the documentation and code the correct CPT. Okay. Again, these are very frequently seen, these CPTs. We have another set of code which we usually, frequently see is regarding myomectomy. So what is myoma?
Muscle tumor.
Sorry?
Muscle tumor.
Yeah, it's a tumor, yeah. Yes, it's a non-cancerous tumor or a benign tumor which grows in the uterus, right? So they can vary in size. Sometimes some women will get a big ball size of a dress. like ball size, isn't it will be the size of football. Okay, so this tumor will what happens once it starts growing, the tumor's ligament, I mean the uterus will expand. So some people might think that the woman is pregnant, but not. She has a tumor. So these tumor can sometimes be small, sometimes can grow very large, uncontrollably. Okay. So if that is the case, we call it as myoma. And if the patient comes in for the resection of myoma, we have certain CPT codes for that. So, so we'll see that. So we have like approaches for myomectomy, that is open and laparoscopic. So if it is open, we need to check whether the myomas are like 1 to 4 or 5 or more myomas. Okay, so if it is just 1 to 4, we need to check the weight of the myoma. So accordingly, we can get the CPT. So the weight of the myoma, if it is 250 gram or less, we have 58140. Okay, and if it is greater than 250 gram, we have 58146. So again, we need to check whether the approach, the removal of myoma approach is through vaginal approach or abdominal approach. So vaginal approach we have 58140 and abdominal, sorry, vaginal approach we have 58145 and abdominal we have 58140. So we'll just see that. So yeah, so you can see here. So myomectomy, excision of fibroid tumors of uterus 1 to 4. Intramural myoma. So we have like subdivision like intramural, submucosal, subserosal. So these are the types of uterine fibroids. Okay. So ICD you need to, code accordingly according to the specification, and CPT you need to check whether the tumors are more than 5 or just 1 to 4. So if the weight size is less than 250 gram, then you have 58140. If it is abdominal approach, again you have 58140. But if the approach is vaginal, we have 58145. And if the tumor size is more than 250 gram, or if the tumors are 5 or more than that, we have 58146. Okay, for the abdominal approach. Why? Because why there is no CPT for vaginal approach for tumors greater than 250 gram? Any idea? Any idea, guys? Am I audible?
The tumor size is big. So
Hmm?
the size is big. So
Yeah, of course, because if there is multiple myomas and if the size is big, you cannot deliver it through the vagina. So definitely you can only do it through the abdominal approach. So that is why you don't have a CPT for that. So 58146, you only have one CPT for greater than 250 gram. Okay. So here the interview question is, what is the difference between uh, abdominal hysterectomy and vaginal hysterectomy? Tell me, guys. Any points anyone can tell? This will be your um interview questions, one of your interview questions. So I'm just like trying to know what you guys know about it. So as we just saw the topic regarding hysterectomy. So the main big difference is that you can note it down, guys. Okay. So an abdominal hysterectomy uses a very large open incision, right, in the abdomen. But laparoscopic surgery or laparoscopic hysterectomy only involves a very small incision and uses a camera and surgical instruments to remove the uterus through that small incision. Okay. So while if patient gets a laparoscopic hysterectomy done, patient will have less post-operative pain, and the scar will be small. There will not be much blood loss during the operation, and also the recovery rate is very fast than the abdominal method. But on the other hand, abdominal hysterectomy may be necessary. Okay, so this is totally on the hands of the doctor. Why? Because the doctor will, if a patient has a myoma, the doctor will tell if he wants to have a abdominal hysterectomy or a what to say, laparoscopic. Okay. If there is only small fibroid tumors, then they will use laparoscopic. Okay, why? Because through keyhole they can fragment the tissues and remove it. But um, if it is big and if it, like there are many multiple fibroid tumors inside the uterus, then definitely the provider will suggest the patient to get abdominal hysterectomy done. Sorry, an open hysterectomy done. Okay. So these are the main points you can share it while an interviewer asks you questions. So yes, incision. I'm just going to reiterate the points again. You can note it down if you want. So the main point is incision. Okay. For this total hysterectomy, you will be having a very big incision in the abdomen, right? But laparoscopic incision will be a very small keyhole injection. It And for abdominal hysterectomy, the procedure is removed. I mean, the uterus is removed through the large opening. But here, laparoscopy, they will insert a scope, okay, through one incision to allow the surgeon to see the organs. And then they will insert the instruments through the scope and perform the hysterectomy. So that is what they do. So the recovery time is typically very long in the open hysterectomy. Okay, so why? Because the patient will have a more post-operative pain and longer hospital stay. But in laparoscopy, very fast recovery. Patient will have less pain. Within 1 week, they will get back to work. Okay, they will have a shorter hospital stay. Okay, so yeah. So mostly, what are the indications for laparoscopic? So if it is a very benign uterine condition, so very small uterus or a very small fibroid, then they will agree in doing laparoscopic. But if there is the uterus itself is large, the patient's uterus is large, and if there is any cancer, okay, so in all these things, they will consider it as abdominal hysterectomy. So I hope you guys have noted down some points, okay? So you can just present it while in interview if you get any questions, okay? So can we see questions? Some two questions we'll see. I want someone to read it and just explain me what is happening. Because every time I'm only reading. Yes, can someone read? It just Badusha. Can you read?
Okay. Okay, sir. A 45-year-old female had multiple uterus fibroids.
Okay. Okay, can somebody else can read?
Yeah, I will read, Sonia. The
Okay, okay, Bhavesh.
gynecologist decided to perform a laparoscopic assisted vaginal hysterectomy. A small infra-umbilical incision was made with a scalpel. A 5 mm laparoscopic sleeve and torca were introduced at three different areas, and under direct visualization, a manipulator was used to examine the patient's pelvic organs. After measuring the ovarian distal pedicles, the endogyne staple was placed across each round ligament. At this time, attention was turned to the vaginal part of the procedure. A speculum was placed in vagina and posterior collectomy was performed. The ureterosacral and cardinal ligaments were clamped, cut and sutured. The anterior peritoneum is entered with scissors and the uterus along with the tubes and ovaries were removed. The total weight of removed uterus is 200 gram.
Okay, okay, thank you, Badusha. Thank you. You can mute, no problem. Yeah. So here you can see the question that if the female is a 45-year-old, she has multiple uterine fibroids. Okay, so she has come for a laparoscopic assisted vaginal hysterectomy. So they have made a very small umbilical incision. Through that, they have inserted a trocar. Okay, and they have introduced trocar at three different areas. So three different areas, they'll make a three different incisions, separate incision, and it will be a very keyhole incision. Only a small incision through which they will pass the trocar. That only space they will create. Okay, and then they will examine, they visualize the structures. Okay, and attention was turned to the vaginal part. Okay, so now they have placed a speculum in the vagina, right? So they just used the trocar. Okay, they made a very small through umbilical incision. They have made this incision, and they have placed a trocar. They just visualized, and then now they after visualizing everything, they will what they'll do. They will just turn to the vaginal part of the procedure. They will place a speculum in the vagina. Okay, and they will clamp the ligaments. Okay, and then they will use scissors and forceps, and they will just go through the uterus and they will remove it. Okay, so they have removed the uterus, tubes, and ovaries. And they have also mentioned the total weight of uterus, which is 200 grams. Okay, so what will be your CPT? And after all these things, they have just removed the laparoscopic instruments. Okay, and they will close the organs with sutures. So in this scenario, we need to check what kind of hysterectomy they have performed. Right, so we have got the weight of the uterus, it is 200 grams. Then we have got that it is the procedure is a laparoscopic assisted vaginal hysterectomy, right? And again, the third point is that they have not only removed the uterus, but they have also removed the tubes and ovaries along with the uterus. So your CPT will be just what is your CPT? So I have just shown you this. You can just tell me the CPT. It is less than 250 gram, and they have removed uterus, tubes, and ovaries, right? And it is a laparoscopic vaginal hysterectomy. So what will be your CPT?
58552.
Exactly. It is 58552. So let's just see another question regarding myomectomy. So a 37-year-old G1PO female was referred for abnormal uterine bleeding. Okay, and causing anemia. Right. So this patient has an AUB, abnormal uterine bleeding, which is causing anemia because she is bleeding a lot. The patient has also experienced heavier and longer menses and dysmenorrhea over the past 6 months. Multiple scattered intramural myomata arranging. Okay, so the patient has a uterine myomata, and what is the type of myomata? It is intramural. Okay, which is documented in the ultrasound. Patient is given a treatment alternative and still desires childbearing. Okay, myomectomy is indicated, and the abdominal approach is recommended. So they have the patient, the provider has, advised for a myomectomy, and that too through abdominal approach. Okay, because of the location of the fibroids, it might be in a complicated state. That is why they are doing an abdominal approach. They have made incision in the abdomen, and they have um, reached the myometrium level to the. Okay, so they have made an incision. Okay, and then they have reached till the myometrium. Okay, down to the fibroids, and then they see that there are three myomas, and they are removing it. Okay, through complex interconnected incision. And they've also given the weight of the myoma, it is 180 grams. And the myometrial defect, the incision is closed multiple layers. So here we need to check is that the patient is having abnormal uterine bleeding. That is why they have come and they have taken ultrasound. So it stated the ultrasound report came as intramural myomata. So that is your primary DX. Okay. Second thing you need to see is that the approach of the procedure is abdominal approach. There are three myomas, and the weight of it is 180 grams. Right. So so it is an open myomectomy, right? So tell me, guys, myomectomy. Okay, three fibroids have been removed, less than 180 gram, and it's also intramural. So what is your CPT?
58140.
5814.
That's it, 58140. Why? Because it is abdominal approach, right? And it is of three myomas with 180 grams. So your CPT is 58140. So this is how you have to code for myomas and hysterectomies. Okay. So all like straightforward CPTs, guys. You can just lead and call it. So what is abortion, guys? Miscarriage. What is the definition of abortion? What is the definition? It is not miscarriage. Okay. It's a term. It's another term for abortion. But I'm asking what is abortion? Sorry. Exactly. Exactly. So that is your definition. Termination of pregnancy, right? By removal or expulsion of an embryo or fetus before it can survive outside. Okay. So abortion is nothing but termination of pregnancy by any means. Okay. So we have types of abortion. So we have spontaneous abortion, we have complete abortion, we have incomplete abortion, we have missed abortion, we have threatened abortion or induced abortion. So spontaneous abortion is nothing but we call it as miscarriage. Why? Why? Because it spontaneously happens. It is not induced. So the fetus will be lost before 20 weeks of gestation. Okay, so that is what we call it as miscarriage or spontaneous. We don't know. The patient might not be aware of what has happened inside, but she'll come to know once a bleeding starts, and that bleeding also will be not so heavy. Okay, incomplete abortion. So incomplete abortion is that the products of conception uh, will only leave the body if any surgical intervention is done. Otherwise, it will be inside the uterus. Okay, the POC we call it as products of conception will be there will be some remaining. So that is what we call as incomplete abortion. Complete abortion sense the products of conception will leave the body without any surgical or medical intervention. Okay, so for example, a patient might have got a spontaneous abortion or we call it as miscarriage. She doesn't know, but she comes in, she says that she has some bleeding, so she wants to check. So the provider will advise for a scan. Okay, it might be an I mean this USC or a transvaginal scan, whatever it is. They will just write order for her and she gets her scan and then she receives a report stating that the patient had a miscarriage. Okay, then in the scan, the patient comes to know, or the surgeon, just informs her that all the products of conception I mean, there is no products of conception and it is all clean. There is no need of any surgical intervention. So in that case, we will, call it as complete abortion. But if the surgeon says that there are some, tissues and, some layers, tissue layers has been remained or some products has been products of conception is staying there. Okay, it's there and she has to get some treatment done like dilation or curettage has to be done in order to clean the uterus. So in that case, we'll take it as incomplete abortion. Okay. Then we have missed abortion. So again, it is nothing but a very silent miscarriage. They won't have any symptoms like bleeding or cramping. So that is why we call it as missed abortion. Okay. So the intrauterine death, fetal death will be before completion of 20 weeks of gestation. Okay, and in missed abortion or a missed miscarriage, the patient won't show any symptoms of abortion, not even pain. Okay, then we have threatened abortion. So threatened abortion is like it's a kind of a vaginal bleeding. Patient will have abdominal cramps, which may indicate that there might be some possible miscarriage happened. So it's a kind of an indication. So that is why we call it as threatened abortion. Okay. Then we have induced abortion. So induced abortion in the sense artificially the patient comes in for a pregnancy termination. I mean, it's her wish. She wants to terminate the pregnancy, unwanted pregnancy. So the provider will give some medications to induce the abortion. So that is what we call it as induced abortion. Okay, so in induced abortion, we have therapeutic abortion and elective abortion. Therapeutic means they will do therapeutic abortion to save the mother if there is any complications or anything. In that scenario, okay, in that scenario, they will come in for an induced abortion to save the mother. Okay, the patient might have the baby might have any birth defect or anything. So in that case, they will try to terminate the baby and make the mother in a safer zone. Okay, then we have elective abortion. It's a type of induced abortion where the termination of pregnancy is done at the request of a woman. So she might request that she wants the pregnancy to be terminated. In that case, we call it as elective abortion. Okay. So these are the terminologies you should be knowing about. The next thing is that the treatment of abortion. So what are the treatment? As I told you, dilation and curettage. So mostly DNC, okay, we call it as DNC in short. So this treatment is done in the first trimester. So what is the trimester, sir? Guys, you need to know the trimester for pregnancy. You guys know what are the trimesters?
Yes, totally 3
Yes,
trimesters.
yes,
Yeah.
3 months.
Okay. What are those?
For first trimester, 1 to 13 weeks, first
Mhm.
trimester. Second
Okay.
is 13 to 20, 28.
Okay, correct. Okay. Huh.
28 to till birth,
Okay, till 40,
third
right?
trimester.
So it can be 38 or 40, depends upon the woman. So, so yeah, so the first trimester, it has, I mean, the trimester period is from um, first week to the 13th week. Okay. Then the second trimester starts from 13 to 28 and from 28 to 40. So all these trimester has its own fetal development. Okay. There might be changes in the mom, right? So, in first trimester, the baby's organs will develop. Okay, the body structure will start growing. And in second trimester, what happens? The baby size will grow. Okay, and the mother can feel baby's, movements inside. In the second trimester, there will be heartbeat. The fetal sounds can be heard from second trimester. And in third trimester, the fetus will continue to grow and develop. Okay, and the uterus will be preparing for the birth. Okay, so likewise, how a baby is developed till from week 1 to week 40. The same way, even there will be a lot of changes in the mother too. Okay, guys, just give me 2 minutes. I'll be back. Okay, guys. So as I told you, there will be changes in the fetal development as well as the maternal mother too. Okay, uh, right. So that is one thing. So in dilation curettage, as I was telling you, this is done in the first trimester. That is from 1 to the 14th. So here the cervix, what they'll do is that they will just dilate the cervix, okay, and they will scrape the uterine lining. So they'll just use a curette to scrape out the products of conception to remove all the abnormal product of conception. It's a kind of a tool. Okay, it has a scraper kind of a texture at the end of the tool, and it will help to clean off the uterine lining. Okay, then we have another treatment we call it as dilation and evacuation, DNE. So this is majorly done in the second trimester. Okay, so they will use some suction method too. So it's a combination of vacuum suction. They will use forceps, they will use vacuum suction and dilation and curettage too. Okay. When this is one guideline, guys, when our DNC and DNE is performed on the same day, you only have to code the DNE, dilation and evacuation. So when they are doing both of treatments on the same day, you should only report for dilatation and evacuation. Okay. Then you have amniotic injection, so intraamniotic injection. So this is a kind of an injection. They will inject a chemical solution. Okay, so through the abdomen into the amniotic sac, right? It's a covering. So inside the amniotic sac, the baby uh, lies, right? So they will inject through the abdomen into the amniotic sac so that the sac, it will cause uterine contraction and it will expel the dead fetus. So this is one kind of approach to remove the fetus, dead fetus. Then we have the vaginal suppositories. So vaginal suppositories are nothing but they will use some tablets. Okay, it can be some, prostaglandin tablets or anything. They will they will insert it inside the vagina. So that this tablet will induce uterine contraction and it will help to expel the dead fetus. We call it as abortion medications, I think. Not sure. So they will just insert it to the vagina and then they will try to expel the dead fetus. Okay. So these are the normally done for treatments for abortion. Now coming to the CPT. CPT from 5820. The CPT is for abortion. So we have 59812. So this is for treatment of incomplete abortion, any trimester completed surgically. So patient comes in for incomplete. Incomplete in the sense the patient will have paradoxical conception inside the uterus and they come for abortion. Okay, complete like just cleaning it through surgical way. And this is for any trimester. It can be like second or third trimester, okay, or first trimester. If that is the case, we will be coding 59812. Okay, now the patient comes in for the treatment of missed abortion. So if your post-operative diagnosis, pre-operative diagnosis missed abortion, and the patient is in its first trimester and they have come for cleaning the taking away the products of conception, then your CPT should be 59820. So this CPT is for treatment of missed abortion, especially in the first trimester. Okay. And if they're coming from the second trimester, then you have 59821. Okay. If the patient comes in for septic abortion, so septic abortion is nothing but the abortion, the dead fetus inside the uterus will become infected, which will harm the mother. If it is not treated properly, if it is not taken out at the right time, it can cause septicemia, the mother causing fever, infection, and all this. Okay. So, if they are coming with a septic abortion and if they are removing it surgically, then your CPT is 59830. And if they are doing an induced abortion by dilation and curettage any trimester, then it is 59840. So in your post-operative diagnosis, they will mention it as induced abortion. Okay. Okay. By the will of that woman, they are coming and they wantedly doing the abortion. So in that case, if it is done by dilation and curettage, we have 59840. If it is done through dilation and evacuation, we have 59841. Okay. So whenever you're coding for abortion treatment, you need to check what is the type of treatment. Okay, and you need to check the type of treatment in the sense whether it is natural, like surgical treatment, whether it is natural or induced. Okay, so if it is natural abortion, you have CPTs. If they come for incomplete abortion, you have the CPT. If they come for missed abortion, you have the CPT. If they come for septic abortion, you have the CPT. Then if it is induced abortion, you need to check whether they have done dilation and curettage or dilation and evacuation. Then if they are doing any injections, intraamniotic injection, so you have the CPT 59850. Okay. Okay, the CPT will cover for by one or more intrauterine injections. Okay. And including hospital admission visits, okay, delivery of fetus and secondary. So what they mean is that this CPT will include all the hospital admission, okay, and the visits. So obviously the patient might need an hospital visit, okay, right? Why? Because the patient will be getting injections, right? So in that case, it is 59850. And if they are doing inducing the abortion with injection and as well as dilation, curettage or evacuation, then your CPT is 59851. Okay. And if they are inducing the abortion by vaginal suppositories, that is tablets or medications through like insert.
Thank you.
Yeah.
Thank you.